So many times your patients will get a report of biliary sludge, but if the patient has had a symptomatic episode of biliary colic, which nearly 70 to 80% will experience, and out of them nearly 90% will have recurrent pain in 10 years. Consider it in every critically ill patient with sepsis or jaundice where you are not able to find any clear source of infection. Do not assume that just because your sonography did not pick up a stone is not there. Many times, gallbladder gets occluded by the gas in the system, in the GI tract, and your sonologist may find it extremely hard to tell you that there is a stone. So any patient who's critically ill with sepsis or jaundice, do keep the possibility of gallstones always in your mind. A few rare conditions which we see, this is gallbladder hydrops, which also is called gallbladder hydrocele. This is a condition characterized by the accumulation of clear mucoid fluid in the gallbladder lumen, leading to its distension. Another rare condition is porcelain gallbladder, where the inner wall of the gallbladder has become hard and calcified. It acquires a bluish color, becomes brittle and hard, resulting in a porcelain ceramic-like appearance.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Today going to be talking about a topic which is very close to my heart, and this is something which surprisingly we haven't discussed in all the time I have been on Medflix. So to rectify that, today I'm going to be talking about gallbladder disorders and their management. And gallbladder disorders and their management constitute a very, very important part of medical as well as surgical gastroenterology. And I hope we can have a stimulating discussion at the end of this brief talk. So the overview of this talk will be to introduce the gallbladder as an organ, look at the disorder overview, the pathophysiology underlying those disorders, how do we diagnose, and finally, since we are all clinicians, how do we manage? So a quick primer on the gallbladder anatomy. This is a bag full of bile which has the fundus, the neck, and the body. It is connected through the cystic duct with the common hepatic duct, which actually has two branches from the liver, the right as well as the left hepatic duct. And when the cystic duct, that is CD, combines with CHD, which is the common hepatic duct, it forms what is known as the common bile duct. Now, as you are all aware, these days it has become very common, and most therapeutic gastroenterologists do ERCP, where they remove stones from the CBD, where they put stents and they cause drainage to be achieved in cases of obstructive jaundice. So this is something which has now become mainstream and is now available in most of the major cities. So please keep in mind that your gallbladder is located inferior to the right lobe of the liver. It connects to the liver and pancreas through the biliary duct system, and therefore its disorders can encompass a wide breadth of diseases that will perforce vary in severity. So the gallbladder disorders, this is not a comprehensive list. I'm talking about things which we see more frequently clinically. The first thing is asymptomatic polylithiasis. Now, what do we mean by that? Asymptomatic polylithiasis is when the patient goes for a sonograph for something else as part of a general health checkup or as part of pain in abdomen and is incidentally found to have gallbladder stones. So polylithiasis basically means GB stones. Then you have biliary colic. Now biliary colic is the pain which is felt when there is distension of the gallbladder, either through infection or through stone or through any other process which leads to a disruption of the biliary drainage. Then you have the condition of acute calculous cholecystitis. This is when you develop inflammation of the gallbladder because of underlying stones inside, and this is of an acute variety which is very severe. It is usually confined to the right hypochondrium, and the patient may or may not have coexisting pancreatitis along with it. Then there is the possibility of chronic cholecystitis, where the patient has stones since a long time, has had repeated episodes of severe or mild or moderate severity, where the pain comes and goes, and the patient continues to have chronic symptoms on and off. So we have the terminology also known as acute on chronic cholecystitis. Then comes the condition of choledocholithiasis, which is the presence of stones in the common bile duct. Now, this is something which is tackled non-surgically by gastroenterologists like me by doing an ERCP and removing the stones. We usually put in a stent, and then the recommendation is to go for lap cholecystectomy to prevent further stone migration from the gallbladder. Cholangitis is the presence of infection in the biliary tract, and it can be secondary to infection in the gallbladder. It can be part of an obstructive pathology, which could be at the periampullary region. It could also be part of a liver pathology leading up to cholangitis. Finally, you have the condition of Mersey's syndrome, where you have stone which is in the cystic duct, which can sometimes perforate and cause a colodocoduodenal fistula, or can cause a content perforation in the cystic duct. The Bouvret syndrome, acute calculus, acalculous cholecystitis are uncommon conditions where you have inflammation of the gallbladder. Functional gallbladder disorder, not a very common condition, but we do see this where the patient has unexplained biliary colic and usually has microlithiasis. Then you have the presence of gallbladder polyps, which can be found. You can get the condition of gallbladder hydrops, which is like the gallbladder is full of limy bile and sometimes is full of fluid. You can have the condition of porcelain gallbladder, where the gallbladder is studded with cholesterolysis and stones. And finally, you have gallbladder cancer, which is on an upside in India, and we now see more and more cases of GB cancer. So, like I said, this is not an exhaustive list of everything which can go wrong with gallbladder, but this probably covers 90 to 95% of what you will see in your clinical practice. So, let's start with the first condition which I talked about, asymptomatic polylithiasis. This is the presence of gallstones in the gallbladder without any associated symptom. Approximately 50 to 70% of newly diagnosed gallstone cases are asymptomatic. The prevalence increases with age and it is higher in females. If you remember your Love and Bailey, we used to get that dictum that fat, female, fertile, faulty. So the 4 F's, and this is where the gallbladder stones were found to be most common. There is also a genetic predisposition, which is the predictive risk factor, and these stones are most commonly found as incidental findings on abdominal imaging. Now, what causes the formation of these gallstones? Gallstones form when the components of bile, which is cholesterol, bilirubin, and bile salts, exceed their solubility, which leads to crystallization. And therefore, the types of gallstones you can get are cholesterol stones, which are yellow, pigmented stones, which can be yellow along with black spots. And then you have the mixed stones, which can be a mixture of cholesterol as well as pigmented stones. So what do you do to manage this? The expectant management is basically observation of asymptomatic patients do not require immediate intervention. I would like to stress this once more. If a patient is absolutely asymptomatic, has 1 or 2 gallstones, you can just ask them to observe, maybe get a sonogram every 6-12 months. If the number of stones is increasing or there are multiple small stones, then one can consider a prophylactic cholecystectomy to prevent the chances of pancreatitis or obstructive jaundice. However, if your patient is regular with follow-ups, you can definitely do an expectant management. It is important to tell the patient about the natural history of gallstones and potential symptoms to watch for, which would be symptoms of right hypochondrial pain, chances of pancreatitis, chances of obstructive jaundice, and one should discuss lifestyle modifications in terms of reducing fatty food and also ensuring that one gives them UDCA, which helps in solubilizing bile. Prophylactic cholecystectomy is considered for patients with specific risk factors like chronic hemolytic diseases like sickle cell disease, where there is an increased risk of gallstone complications, patients undergoing solid organ transplantation, particularly within the first 2 years post-transplant. Surgical intervention is not recommended for asymptomatic patients. Surgical option should be discussed if symptoms develop or complications arise. My personal dictum is that if I get a patient who's a poorly controlled diabetic, if the patient is less likely to be regular in the follow-ups, if this patient is obese, even if the patient is asymptomatic, I advise them to undergo a prophylactic cholecystectomy if they have multiple small GB stones. The reason being the chances of migration of these stones from the gallbladder into the common bile duct, leading thereon to potentially the possibility of pancreatitis and obstructive jaundice is extremely high, and these patients do well with prophylactic surgical intervention. However, like I said, this is not always the case. You should pick your patient carefully and then subject them to surgery. Expectant management will work well with young patients who are regular in follow-up, who do not have the risk factors which I mentioned, and who are very likely to follow the lifestyle modifications and regular follow-up and monitoring as advised by you. So biliary colic is the type of abdominal pain which is caused by the temporary obstruction of the cystic duct or the common bile duct by gallstones or biliary sludge. So many times your patients will get a report of biliary sludge, but if the patient has had a symptomatic episode of biliary colic, which nearly 70 to 80% will experience, and out of them nearly 90% will have recurrent pain in 10 years. This is an episodic intense pain in the right upper quadrant or epigastric region. It can radiate to the right shoulder or scapula, can last from a few minutes to several hours, and may also resolve spontaneously. Associated symptoms can be nausea, vomiting, diaphoresis, belching, and bloating. Usually the patients appear to be stable and afebrile, but if the patient has fever, is looking toxic, this is a patient who after stabilization is a definite candidate for cholecystectomy. So the pathophysiology for biliary colic is when a gallstone temporarily obstructs the cystic duct, it leads to an increased intraluminal pressure and distension of the gallbladder. This obstruction triggers gallbladder contractions, resulting in visceral pain, and the pain typically follows meals due to the release of cholecystokinin, which is a vasoactive peptide which stimulates gallbladder contraction. So how do you diagnose this? The lab test would include a complete blood count, which would usually show a high ESR, a high CRP, and a raised total count, a metabolic panel to rule out conditions like hypertriglyceridemia, and a liver function test. Absence of leukocytosis will help you distinguish biliary colic from acute cholecystitis, where there would be a definite leukocytosis, which is significant. How do you manage this? The first dictum is to control the pain, which is the primary focus. This will usually involve NSAIDs. You could even give opioids for those who cannot tolerate NSAIDs or where the pain severity is very severe. Fasting will effectively reduce the release of cholecystokinin and gallbladder contraction during frequent episodes of biliary colic, and therefore many of these patients are kept nil by mouth and given IV fluids. The definitive treatment obviously is elective cholecystectomy, which is recommended for recurrent biliary colic patients who are definite surgical candidates. Now to the second condition, which is third condition, acute calculous cholecystitis. This is an inflammation of the gallbladder due to the obstruction of the cystic duct by gallstones. This leads to stasis of bile, infection, and inflammation. This will account for nearly 1 out of 5 patients admitted for biliary tract disease. Like I've already said, gallbladder disease per se is more common in women. It is found more often, more than half of your patients will be women. The symptoms are sudden onset of right upper quadrant pain, which is usually quite severe and persistent. It is usually associated with nausea and vomiting, and fever and chills are also a usual accompaniment. If you look at the physical examination, there is a positive Murphy's sign, which is pain when you palpate the right upper quadrant. It's a very, very simple test one can do, and tenderness in the right upper quadrant with possible guarding is also something we see occasionally with acute calculous cholecystitis. The pathophysiology, like I said, is basically gallstones leading to obstruction, causing increased pressure within the gallbladder. This leads to inflammation, which causes mucin production and bile stasis. This causes ischemia, edema, and inflammation of the gallbladder wall. And finally, you have the stage of infection where bacterial infection may occur, common pathogens being E. coli and Klebsiella species. And one needs to be aggressive with the antibiotic coverage for these patients. One needs to choose antibiotics which have good biliary penetration and we'll talk about it soon. So the guidelines for diagnostic and severity criteria are many, but what I look for as a positive Murphy's sign, the presence of a mass in the right upper quadrant, a sick patient with fever, elevated CRP and leukocytosis. You could find imaging findings like which could give you a definitive diagnosis or a suspected diagnosis when you see inflammation in sonography. Grade 1 is usually acute cholecystitis with no organ dysfunction and mild inflammation in the gallbladder. Grade 2, which is moderate, you will have increased total white cell count, palpable tender mass occasionally. Duration of symptoms would be at least exceeding 3 days, and there would be marked local inflammation in the form of either gangrenous cholecystitis, pericholecystitic abscess, hepatic abscess, peritonitis, and emphysematous cholecystitis. Then you have the extremely sick patient, the grade 3 severe one, where there is evidence of organ dysfunction, which means the patient may be hypotense, there would be decreased level of consciousness, oliguria, and a PaO2 and FiO2 ratio which is less than 3. So how do you manage these patients? Initial supportive care is through hydration with IV fluids to maintain volume, pain control through either NSAIDs or opioids, and antibiotics, which would be broad spectrum antibiotics. They could start with meropenem, imipenem, or you could use 4th generation cephalosporins. Then you have surgical intervention. The timing has to be right. I personally prefer early laparoscopic cholecystectomy, ideally within 24 to 48 hours of diagnosis. One must keep in mind high-risk patients and those with significant comorbidities like morbid obesity, uncontrolled diabetes, patients who are cardiac risk. The post-operative care, one needs to keep in mind to monitor for complications in terms of organ dysfunction. And finally, you have to educate the patient on recovery and dietary modifications post-surgically. The next condition, chronic cholecystitis. This is just an add-on to the one which we discussed earlier, which was acute calculous cholecystitis. Here there is a prolonged inflammatory condition of the gallbladder, often associated with the presence of gallstones. It can occur in patients with or without gallstones because you can get cholecystitis due to other reasons apart from stones. So some studies indicate that up to 13% of the patients may have no gallstones at the time of cholecystectomy. The pathophysiology is not fully known, but we know that there is a strong association with polylithiasis, and clinical presentation is usually non-specific with nausea, reflux, bloating, mild upper abdominal discomfort, and many of these patients are picked up incidentally when they are asymptomatic. So the diagnosis is usually based on the histology of the gallbladder when it is removed. There is a chronic inflammation of the lamina propria associated with fibrosis and or metaplastic change. Ultrasound and CT imaging findings are usually non-specific. However, there is a common finding of presence of gallstones and significant gallbladder wall thickening, which indicates chronic fibrosis and a long-standing disease. The treatment is definitely elective laparoscopic cholecystectomy in patients with chronic calculous cholecystitis. The complications can be acute on chronic cholecystitis and gallbladder carcinoma, which is known to have a significant association with patients who have chronic calculous cholecystitis. The next condition is choledocholithiasis. This is again a complication of gallstones. So choledocholithiasis is the gallstone which has migrated from the gallbladder into the common bile duct. And this incidence again increases with age. The risk factors are similar to those of cholelithiasis, and the clinical presentation is usually right upper quadrant pain. It could be associated with jaundice, which would be of the obstructive variety, and the Courvoisier sign, which is palpable gallbladder on palpation due to bile accumulation, is found in more than 70% of these patients. When we talk about primary choledocholithiasis, the pathophysiology is stones formed directly in the bile ducts. They are usually associated with conditions that cause bile stasis, which can be in the form of CBD strictures, which can be benign or malignant, and infections. Then you have secondary choledocholithiasis, which we see more commonly, where the stones migrate from the gallbladder into the CBD. These are typically cholesterol stones. How do you diagnose? I already told you there would be pain and there would be a clinical evaluation which would suggest history of biliary symptoms and physical examination findings. Your imaging studies, ultrasound detects gallstones and CBD dilatation along with intrahepatic biliary radical dilatation. CTs are useful for confirming the presence of stones and assessing any secondary complications. MRCP is something I use very frequently. It's a non-invasive imaging technique to visualize the biliary tree and confirm choledocholithiasis. And finally, ERCP, which can be both diagnostic and therapeutic, though these days none of us who are interventional gastroenterologists, we don't do diagnostic ERCPs these days. Whenever an ERCP is done, usually it is only for a therapeutic purpose where we can remove the stones from the CBD, and then we can definitely put in a stent to ensure that the cholangitis subsides, the bile flow is maintained, and all the CBD dilatation subsides before the patient goes for a lap chole. And the stent helps the surgeon also because it allows them to avoid the CBD during laparoscopic cholecystectomy, thereby preventing any inadvertent CBD damage. There are a lot of predictors of choledocholithiasis as defined by American Society of Gastrointestinal Endoscopy. Personally, I feel if you have patients who have common bile duct stones on ultrasound with clinical acute cholangitis, it doesn't matter even if the bilirubin may not be more than 4 as prescribed by ESG. I consider it a very, very strong predictor of significant choledocholithiasis. And these patients definitely need clearance of the CBD through an ERCP and then be subjected to elective laparoscopic cholecystectomy. So the management here would be ERCP as the first line treatment, and then for low risk patients, patients who are symptomatic, they should straight away go for an elective laparoscopic cholecystectomy. For intermediate risk patients, I would definitely want to reconfirm my diagnosis where there is any doubt with either an endosonography or an MRCP, and if stones are confirmed, I would proceed with ERCP. The next important clinical condition is acute cholangitis. Now, this is a superimposed bacterial infection of the biliary tree. The pathophysiology is obstruction of the bile duct, which increases intraductal pressure. This leads to bile stasis. Stagnant bile will allow for bacterial overgrowth. This will result in infection. The common pathogens are E. coli, Klebsiella, Enterococcus, and Enterobacter. These will pretty much your garden variety of patients, nearly 75% will have these common pathogens. Please keep in mind the Charcot's triad, which consists of high fever, jaundice, and abdominal pain. This is the classical picture you see with acute cholangitis. Then you have very severe cases which may have what is known as Reynolds pentad, where you have these three things which are there in Charcot's triad, like high fever, jaundice, and abdominal pain, but you also have coexistent hypotension and altered mental status. Now, that is a very seriously ill patient and is a patient who is in ascending sepsis, and the mortality can be as high as 30 to 40% even today if aggressive intervention is not undertaken. So, this is how we usually diagnose the Tokyo guidelines, as we call them, where there is a group A with systemic inflammation with fever and raised acute phase reactants like WBC and CRP. Then you have the group B patients who have associated cholestasis, where there would be presence of jaundice and altered liver enzymes. Then you have the group C patients who have imaging findings with evidence of biliary dilatation and imaging which shows you stones or obstruction or a mass. This can be either through ultrasound, MRCP, or EUS. And then you have a definite diagnosis when you have more than one positive finding in group A, B, or C, and a suspected diagnosis when you have more than one positive finding in group A and more than one item in B or C. How do you manage? Initially, administer intravenous fluids, correct any electrolyte imbalance, initiate broad spectrum intravenous antibiotics targeting gram-negative and anaerobic bacteria, which could be piperacillin, tazobactam, ceftriaxone, plus metronidazole. And very important, biliary drainage has to be achieved. So you do an ERCP at the earliest. This is critical for relieving obstruction and draining infected bile within the first 24 hours. Removal of stone and stent placement may be performed, and this gives usually a quick settling down and a definitely improved prognosis for these patients. Another interesting clinical condition, which is Mersey's syndrome. Now, this is biliary obstruction that develops due to a cystic duct or gallbladder neck stone externally compressing the proximal bile duct. It is again a complication of cholelithiasis. Usually, it's a large stone or multiple small stones which lodge in the Hartmann's pouch or the cystic duct. They compress the proximal bile duct, and this leads to jaundice. Clinical presentation, usually these patients present with signs of obstructive jaundice, which would be elevated bilirubin levels, along with right upper quadrant abdominal pain, nausea and vomiting, would be associated with fever, and physical examination along with reports would show you right upper quadrant tenderness. Blood reports would show elevated alkaline phosphatase, which would suggest stasis and cholestasis, and increased bilirubin levels. How do you diagnose this? Many times, initial imaging through ultrasound, which is done for assessing gallstones and shows you biliary dilatation along with obstructive jaundice, can point you in this direction. But more specific, for identifying the cause of obstruction and assessing the biliary tree would be a CT scan. MRCP is again very useful in this condition as it's a non-invasive imaging technique to visualize the biliary tree. And ERCP, like I've already told you, can be both diagnostic and therapeutic to confirm the diagnosis. But these days we do not use ERCP for diagnostic purposes. We would straight away do an ERCP for a therapeutic purpose. So cholecystectomy is recommended for definitive treatment to prevent recurrence of varices, or oral cholangioscopic therapy can be considered in very sick patients who cannot be taken up for an elective cholecystectomy. And ERCP must be definitely performed to relieve obstruction and manage any complications before surgery. Bouvret syndrome, which is a rare form of gallstone ileus, where a gallstone passes down, obstructs the duodenum, and this leads to a gastric outlet obstruction. So here is a stone which to start with was in the gallbladder and has now moved through the common bile duct and gets passed on into the duodenum. The stone is large enough to cause a blockage of the duodenum, and this leads to a condition of gastric outlet obstruction. This is a complication of cholelithiasis. Patients will usually present with nausea and vomiting, abdominal pain and discomfort, early satiety and dysphagia. And the pathogenesis is that it is the severe inflammation which causes the gallstone to erode through the gallbladder wall. This creates a cholecystoenteric fistula, and the gallstone passes through this fistula into the GIT and becomes lodged in the duodenum. It's a rare condition, but it is to be kept in mind whenever you are looking at a gallstone which is large and can lead to what is known as the Bouvret syndrome. And this is gallstone ileus due to an impacted gallstone in the duodenum. How do you diagnose this? I think a simple abdominal X-ray will show you signs of bowel obstruction and pneumobilia. A CT scan can occasionally pick up the obstructing stone and also give you the site of obstruction. And many times we rely on what is known as a gastroduodenoscopy, which is an upper GI scopy, which will usually show us the stone, and many times we are able to disimpact the stone through endoscopy. However, this has a lower success rate if it is beyond D2, D3. Usually we will find it difficult, but nowadays with enteroscopy, we are able to, through minimally invasive techniques, pass this stone on or even crush it. Many times we can use surgical intervention also to treat these patients, where an enterolithotomy or a gastrostomy is the treatment of choice. Cholecystectomy will need to be done, and the fistula repair will also need to be performed in these patients. Acute calculous cholecystitis, something which I have kept towards the fag end of the causes, mainly because this is something we all see very commonly. This is an acute necroinflammatory disease. It can occasionally be a difficult diagnosis to meet. You should have a high clinical suspicion and a high index of suspicion. Consider it in every critically ill patient with sepsis or jaundice where you are not able to find any clear source of infection. Do not assume that just because your sonography did not pick up a stone is not there. Many times, gallbladder gets occluded by the gas in the system, in the GI tract, and your sonologist may find it extremely hard to tell you that there is a stone. So any patient who's critically ill with sepsis or jaundice, do keep the possibility of gallstones always in your mind. The pathophysiology is bile stasis and ischemia of the gallbladder. These are the key factors, and they contribute to this acute acalculous cholecystitis. The factors which also promote acute acalculous cholecystitis are prolonged fasting or parenteral nutrition, sepsis or systemic inflammatory response syndrome, trauma or major surgery, vascular compromise leading to gallbladder ischemia. So, how do you start diagnosing and managing this. So in the ultrasound is the first line imaging, you will see gallbladder wall thickening, pericholecystic fluid, intramural gas, echogenic biliary sludge, hydrops and or sloughed mucosal membrane. CT scan can provide you more detailed information, like I said, and it is also useful because it provides you information about the surrounding structures. Occasionally, you can use a radioisotope scan known as the HIDA scan to assess gallbladder function. This is something we use very rarely, but I just thought I should mention it because it is an option which can be considered. Cholecystectomy is your treatment of choice, can be performed laparoscopically these days or open, depends on the patient's condition. Many times, if the patients are high risk and are not candidates for surgery, we also advise for what is known as a percutaneous cholecystostomy, where there is a drainage achieved through external means and the patient is treated in a non-invasive, in a minimally invasive way. Laparoscopy is favored as it can be both diagnostic and therapeutic. So again, like I said, laparoscopic cholecystectomy is the mainstay when it comes to removal of gallbladder in these conditions. Functional gallbladder disorder, I thought I should talk about because we all look at a lot of functional GI disease and gallbladder is no different. These are a group of conditions which are characterized by gallbladder dysmotility without any identifiable structural abnormalities or gallstones. The cause is multifactorial, which is considered to be impaired gallbladder emptying due to dysmotility or abnormal response to hormonal stimulation or visceral hypersensitivity leading to exaggerated pain responses. Symptoms are typically biliary colic, which is in the right upper quadrant, or epigastric area. Pain can often occur within 30 minutes of eating, can last as long as 6 hours, and associated symptoms may include nausea, vomiting, occasional fever, and chills. How do you diagnose? I think a sonogram is used to exclude structural abnormality and show no evidence of gallstones or sludge. Occasionally a HIDA scan, but laboratory tests like liver enzymes, lipase, and amylase are typically normal. So many times this is a diagnosis of exclusion, and a HIDA scan helps us by measuring gallbladder ejection fraction. Just like you do a 2D echo to look at the ejection fraction of the heart, a HIDA scan tells us what is the ejection fraction of the gallbladder, and anything less than 40% is considered abnormal and indicates that this patient has dysmotility. Conservative treatment would focus on symptom management with antispasmodics. Neuromodulators may provide relief. UDCA has been considered with good results in some cases. Finally, there is surgical intervention for patients who are having recurrent symptoms and where conservative measures fail and there is a significant impairment of quality of life. These are the patients who definitely benefit with surgical intervention. Gallbladder polyps, we see quite frequently. Many times patients come to us that should we get a surgery done for this? These are growths that protrude from the gallbladder mucosa into the lumen. Symptoms may not be present and these could be incidental findings and they could be seen before one goes for a cholecystectomy or even stones. Sometimes it's difficult to say that it's a polyp or a stone because you have what is known as calcification of these polyps also. They can present with non-specific symptoms like pain, nausea, vomiting, dyspepsia, jaundice, and many times it has been said that they could actually be precancerous, though the jury is still out on that. Sometimes we can get a positive Murphy's sign when we palpate. The risk factors are familial polyposis syndromes, hepatitis B infection, increased age over 60, presence of gallstones, primary sclerosing cholangitis. It is also postulated that smoking impacts the formation of polyps. Polyp size, growth rate, and gallbladder wall thickening are important considerations to keep in mind before you subject these patients to a cholecystectomy if symptomatic. So looking at the polyps, the non-neoplastic polyps are usually 95%. These are cholesterol polyps, adenomyomas, inflammatory polyps. They do not need surgery as a mandatory routine. Where you have neoplastic polyps, adenomas which are considered pre-malignant and malignant polyps, obviously one would need to go for surgery. Now the question would be, how do we realize that these are neoplastic or not? The idea should be that if you have patients who have any underlying malignancy with polyps, these are patients for an elective lap cholecystectomy. If you have a patient who's symptomatic, who already has stones, these patients again would benefit with lap cholecystectomy. However, a large majority of these patients do not require anything except close monitoring, just like asymptomatic gallstones. You can continue watching If you do not see any deterioration in your patient, this is not a candidate for surgery as a mandatory routine. However, if you want to have peace of mind, if your patient wants 100% surety, these are patients who can go for a planned elective lap cholecystectomy. So the diagnosis, again, ultrasound, CT scan, MRI, as we have discussed, in a rising pattern of investigation. One should evaluate for malignancy. Keep in mind that if you have polyp size more than 1 centimeter, which are growing very rapidly, and there are present gallstones, these are patients who will definitely benefit with surgical intervention. However, for the rest, the small asymptomatic polyps, which are less than 1 centimeter, typically will just require follow-up regularly with ultrasound, maybe once or twice in a year. As I come towards the end of my talk, a few rare conditions which we see. This is gallbladder hydrops, which also is called gallbladder hydrocele. This is a condition characterized by the accumulation of clear mucoid fluid in the gallbladder lumen, leading to its distension. It's a rare condition, like I said. Prolonged obstruction of the cystic or biliary tree leads to the accumulation of fluid. Bile salts get reabsorbed, they get replaced by a clear watery mucus, and this results in gallbladder distension. Most common finding is right upper quadrant pain with a positive Murphy's sign. On CT scan, you will see very clearly this gallbladder hydrops as shown in this CT. Many of these patients may be asymptomatic but may have symptoms which worsen when they take greasy or spicy food associated with flatulence, nausea, and vomiting. Again, the treatment, if symptomatic, is laparoscopic cholecystectomy. Like I said, imaging studies would be ultrasound and CT scan. Here, liver function may be normal or deranged if there is a presence of biliary obstruction or infection. Asymptomatic patients observe support with a low-fat diet to minimize gallbladder stimulation. Surgical intervention can be through laparoscopic cholecystectomy, which I personally prefer. Intraoperative fluid aspiration we usually do to reduce morbidity during laparoscopic cholecystectomy, though these days even that is not required. And for those patients who are very sick with presence of empyema, which is pus formation in the gallbladder, percutaneous drainage can be tried out till the patient is stabilized, and then we minimize the risk of perforation and remove the gallbladder through a laparoscopic cholecystectomy. Another rare condition is porcelain gallbladder, where the inner wall of the gallbladder has become hard and calcified. It acquires a bluish color, becomes brittle and hard, resulting in a porcelain ceramic-like appearance. Approximately 95% of these cases are associated with gallstones. Many of these are asymptomatic. Symptoms are typical of chronic cholecystitis like right upper quadrant pain, nausea and vomiting, and dyspepsia. Pathophysiology is not exactly understood, though we all know that chronic inflammation is the driving factor. There is dystrophic calcification which can occur due to chronic inflammation. Alternative theory is obstruction of the cystic duct leads to calcium salt precipitation in the gallbladder mucosa and gallstone formation, which represents a progression where insoluble substances supersaturate the bile, leading to porcelain gallbladder. Again, imaging is the key. Ultrasound, CT scan, MRI. Evaluate for malignancy risk because these patients are associated with extensive calcification and have a definite increased risk of gallbladder cancer. My personal recommendation is do a cholecystectomy for symptomatic patients because there's a high risk of malignancy. If your patient is asymptomatic, you could consider monitoring, but with porcelain gallbladder, I always recommend a laparoscopic cholecystectomy because there's a very high associated risk of CAGB. And CAGB is one of those cancers which tends to be indolent and grows slowly, which is the last condition I'm going to be talking about. This is the sixth most common GI malignancy, more common in women above the age of 65 years. Many of these patients, unfortunately, are asymptomatic, and by the time they present to us, the disease is well spread. The risk factors, which are non-modifiable factors, are age, more common in females. Increasing age is obviously a risk factor, and ethnicity, it is found more in American, Indian, and Asian population. There are modifiable factors like chronic inflammation due to chronic cholecystitis and porcelain gallbladder, which I have already alluded to in my talk, where a prophylactic laparoscopic cholecystectomy is beneficial. Gallstones and gallbladder polyps, which are large in size, obesity, metabolic syndrome, environmental exposures to heavy metals, chronic infections like Salmonella and Helicobacter pylori are also known to be triggers for gallbladder cancer. Again, the carcinogenesis not fully understood. It's a multi-stage transformation. of normal gallbladder epithelium through metaplasia, dysplasia to carcinoma in situ and eventually invasive carcinoma. We know of genetic alterations like KRAS mutation. Tumor suppressor genes like P53 play a critical role in the development of GB cancer. Things are still quite dismal when it comes to treatment of gallbladder cancer because most of these patients tend to present quite late in the day. Diagnosis would be usually through an ultrasound, EUS, CT scan, and an MRI, and finally a biopsy, which these days we do through an endoscopic ultrasound, fine needle aspiration for definitive diagnosis. The management, if you can do curative surgery, if the disease is, it is dependent on the tumor stage. So if it is still involving only the gallbladder, curative surgery is possible. These days, of course, we do laparoscopic surgery, but open surgery is preferred because it avoids risk of tumor seeding, which is known to happen with laparoscopy. The stages and treatment are from T1A to T4. Chemotherapy agents which have come into their own over the last few decades are gemcitabine, fluoropyrimidines, and platinum compounds. But again, like I said, this is a disease which is quite dismal, and our prognosis is not so good because most of these patients tend to present in fairly advanced disease like T3, T4. The overall 5-year survival rate for gallbladder cancer is approximately 5 to 15%. Early stage disease obviously has better prognosis. Advanced stages have a much more dismal prognosis. And 5-year survival rate, like I said, is nothing much to be very happy about. The risk of GB cancer is 2 to 6 times higher for women, as I've already said. Thank you very much. And I can see there are a lot of questions, and hopefully we can have a very good discussion. Over to you, Barsha.
Thank you so much, sir, for a very detailed talk on gallbladder disorders. And yes, there are a lot of questions from our doctor. We will be getting into that. I'm going to be taking one of the earlier questions that we had. So Dr. Sunil says, feels GB perforation with omentum with sepsis. What should be the choice of treatment modality if patient is unfit for surgery?
Tricky question, Dr. Sunil, but I'll try to answer it to the best of my ability. This is obviously a very sick patient, and you have a sealed GB perf with omentum probably causing the sealing off of the GB perf. But since you say that the patient has sepsis and is unfit for surgery, I'm assuming the patient is on pressors and maybe has altered mentation or multi-organ failure. Now, if you can't do a cholecystectomy, which is finally the thing which will settle down this perforation, the next best option is to do a drainage, which can be either through a radiological procedure where you puncture the gallbladder and you drain this, which is something which is not preferred most of the times, or you do what is known as a limited cholecystostomy and thereby drain this patient, put him on higher antibiotics, take care of whatever organ dysfunction is, and then once the patient stabilizes with all the risk of being unfit for surgery, the patient is only going to settle down once you do a cholecystectomy. In this patient, I would definitely suggest not doing a laparoscopic removal. This should be something which is done as an open surgery and a proper wash with cleaning of the whole area, because you're talking about sepsis. You would be surprised how well these patients settle down once the infected part is taken out. So the final goal has to be to take the patient up for a cholecystectomy. But obviously, if the patient is not fit for immediate surgery, then a cholecystostomy is a good halfway measure.
So next by Dr. Maheshwari, what are the common pre-malignant conditions that are seen in middle-aged patients?
Is that a general question, or are you talking about gallbladder specific patients? Because I think common pre-malignant conditions seen in middle-aged patients are just about anything. It could be leukoplakia, it could be polyps in the gallbladder, it could be colonic polyps, it could be an enlarged prostate. I mean, if it's a female, you could be talking about cervical CA due to fibroids, uterine fibroids, and infections and all. So I'm sorry, Dr. Maheshwari, I don't get the drift of your question. But since we talked about gallbladder, let me talk about the pre-malignant conditions we see in middle-aged patients who have gallbladder pathology. So these pre-malignant conditions would be a porcelain gallbladder. These could be a patient who has chronic calculous polylithiasis. And you would also look at conditions like patients who have repeated liver flukes and infections, biliary strictures. These are the pre-malignant conditions we see in middle-aged patients pertaining to the gallbladder.
Next from Dr. Gautam, what all conditions can we suspect in case of intermittent jaundice?
Yeah, great question, Dr. Gautam, and thanks for asking that question. I think the most important thing to suspect in cases of intermittent jaundice, first of all, is choledocholithiasis, because these are patients who probably have small stones which keep passing out of the CBD. They lead to some jaundice when there is some element of obstruction, and if the stone passes away, the jaundice gets relieved. Then I have another stone which gets impacted. This is one condition. The second thing is liver flukes and worm infestation of the CBD can also give rise to intermittent jaundice. So they tend to form a ball, and many times they can lead to intermittent jaundice. The third thing to keep in mind is sickle cell disease. And sickle cell disease again is something where you can get intermittent jaundice.
Dr. Rajan asks relation of diabetes patient to gallstones.
A straightforward relation exists between diabetes and gallstones. Any patient with long-standing diabetes, which is considered as anything more than 5 years, are having a increased 3 times increased risk of getting gallstones. The reason being that diabetes per se, due to its tendency to cause neuropathy, autonomic neuropathy, also impacts the solubility of the bile because it decreases the gallbladder contraction, and these patients are having an increased risk of gallstones. So there's a straightforward correlation between diabetics and gallstones.
Next, Dr. Mishra says, what is the treatment of asymptomatic GP stone?
I've already covered this, Dr. Mishra, in my talk, but just to briefly summarize, if you have asymptomatic gallstone which is not increasing in size or number, and the patient is young, is in regular follow-up, and is willing to get a sonogram every 6 to 12 months, you can just wait and watch. If you have a patient who is less likely to be compliant in his follow-up, if the patient is diabetic, is obese, has other metabolic parameters which are not too good, this is a patient who's, even if he's asymptomatic, you should subject to a laparoscopic cholecystectomy. However, please keep in mind that whenever you have an asymptomatic GB stone patient, please prognosticate them that at any point in time, an asymptomatic stone can become symptomatic. So they need to know this, and obviously the first sign of a symptom, the treatment has to be curative, which would be a laparoscopic cholecystectomy.
Dr. Kulkarni says post-op status after removal of gallstones, and also oral surgeons used to invert the gallbladder. Is it still in practice?
No, this is not something in practice anymore, Dr. Kulkarni. There's no gallbladder left. There's no question of inverting anything now. This was when there was a partial cholecystectomy done. With the total cholecystectomy, there is nothing left. So you don't have anything to invert. It is not being done anymore.
Next question from Dr. Desai. Any role of statins in prevention or reduced risk of gallstone formation, as most stones are cholesterol stones?
As of now, sir, there is no evidence that statins prevent or reduce risk of gallstone formation. There are no studies to suggest the same. It is an attractive hypothesis, as most of the stones are cholesterol stones. But my theory is that most of the cholesterol stones tend to happen mainly because of dysmotility of the gallbladder, where statins would have no role per se. It is the dysmotility and the decreased solubilization function of the bile in the gallbladder which leads to precipitation of these stones. Therefore, we do not personally use statins for prevention or reduction of risk of gallstone. The only thing which we use with very limited success is UDCA, which is ursodeoxycholic acid, to prevent more solubilization of bile. However, let me say that that also is a very, very unsatisfactory sort of a measure. So the only thing which actually works is by reducing fat intake, reducing weight, and ensuring that one goes for a prophylactic lab chole at the first sign of decompensation.
Another question from Dr. Desai was role of dietary instructions and role of oral digestive enzymes with a cholecystectomy.
Yes, sir. The role of dietary instructions is definitely vital. These patients initially post cholecystectomy tend to have bile acid diarrhea. Usually that settles down in 4 to 6 weeks. If it is significant enough, we would want to give bile acid sequestrants like cholestyramine, and therefore we would also ask the patient to avoid very fried and spicy and fatty food. The role of oral digestive enzymes is that it helps with the dyspepsia, which many patients get as part of post cholecystectomy syndrome, where they tend to reduce the gassiness and the distension post meals which these patients have. So, what we tell them is to have small meals, not to overfeed, and to try and walk post meals for at least 30 minutes before lying down. Also, the role of losing weight and having the right sort of diet in avoiding fatty food and milk products and so on should always be emphasized. And for those who are diabetics, we would also want them to have strict control of their diabetes, because that also helps in the settling down of these symptoms.
So we have quite some questions on GB carcinoma, so I'm addressing it together. Uh, First, incident percentage of GB carcinoma and chronic cholecystitis.
Can range anywhere from 6 to 14% depending on which study you are looking at, Dr. Mishra. There are areas in India like the north of India where the incidence of CAGB is quite high. Then there are pockets in south where the GB carcinoma is quite high. The state I come from, Gujarat, we see an intermediate sort of incidence of gallbladder carcinoma. Again, it is very high in the northeast. So it all depends which area we are talking about. There are epidemiological factors, there are dietary factors which lead to chronic cholecystitis and thereon the formation of gallbladder carcinoma. However, if you're looking at an absolute percentage, I think you can't go wrong with the percentage of 6 to 8%.
Dr. Arun says, is ARCP CBD stenting indicated in patient with passed out CBD calculus?
No, not at all. If your CBD stone has passed out and there is no evidence of a biliary tree obstruction, there is no indication even to do an ERC. If the stone has already passed out, all you need to do is, of course, once you have confirmed with an MRCP, now you would ask your surgical colleague to go ahead and do a laparoscopic cholecystectomy to prevent any further stone migration. So a stone which has already passed out does not require an ERCP. It's only when you have a suspicion that there are stone remnants or a stone still left behind, you see evidence of a dilated CBD, dilated IHBR, and signs of obstruction in terms of raised alkaline phosphatase and acute phase reactants. That is the time to go ahead with a ERCP, clean the CBD. If required, put in a stent. If you are very confident that you've already cleaned it up, a stent is again something optional. I personally prefer putting in a stent because it serves as a good marker for my surgical colleague when he does the lab coding.
Next, Dr. Sunita Thomas asks, will liver enzymes be raised in biliary colic? Causes for AST and ALT more than 200 for patient with multiple GB stones. With biliary colic, USG shows common bile duct normal.
Yeah, great question, Dr. Sunita. Something we see very commonly in clinical practice. Liver enzymes are usually raised in biliary colic by a very small amount. These will not be scarily high, but you could get 2 or 3 times higher levels than the normal. And it's not always the case, but you will see it in about 40 to 50% of the patients. So maybe half of the patients with significant biliary colic will have raised liver enzymes. The causes for AST and ALT being more than 200 for patients with multiple GB stones with biliary colic with a normal CBD can be many. There could be viral infection for one. It could be an obstruction. It could be cholangitis. It could be the fact that it could be a developing Meniere's syndrome. So there are multiple reasons for AST and ALT to rise. Usually they will rise, but not very significantly like the type you see in viral hepatitis.
Next, Dr. O.P. Gautam asks, at what size of gallstone cholecystectomy is required?
I don't think we look at size of gallstones, Dr. Gautam. As a matter of fact, if you have small, multiple stones, that is a more important indication for cholecystectomy rather than to do it, say, with a large solitary stone, which one can monitor. So it is not the presence of the size. However, any patient who has more than 5 centimeter large gallstone is usually an absolute candidate for cholecystectomy. because these are the patients who are more likely to have complications like empyema and CAGB and all due to chronic cholecystitis.
So, just ask us when to remove the stent from common bile duct after cholecystectomy. Also, when to consider cholecystectomy after putting stent for bile duct stone.
So, Dr. Jiten, that's a great question again, and thanks for asking that because that's a very, very relevant clinical issue. We should consider cholecystectomy anytime after putting stent for bile duct stone once your cholangitis has settled and the patient is having decrease in jaundice. So, my personal preference is to ask my surgeon to go in at 48 hours post putting in a stent. However, there are lot of papers which have said that it is better to wait for a week and then do it. I personally believe in going in early and taking out the gallbladder before there are signs of sepsis which set in. When to remove the stent post cholecystectomy can be any time after 4 weeks post cholecystectomy. Also keep in mind before going in with an endoscope, one should get a sonogram done. Many of these stents pass off spontaneously, and you may not even require to remove the stent endoscopy. So 4 weeks is what is my personal choice. Though one can remove the stent even a week after cholecystectomy. Personally, I believe in doing it after 4 weeks. By that time, the stitches and all have come off. The healing has happened. The patient is much more stable, and the stent there does not hurt. Many times it will pass off spontaneously in about 20 to 25% of your patients. The rest of the patients, we can definitely go in and easily remove the common bile duct stent.
There's another question from Dr. Shah. When to consider surgery for gallbladder polyp, and does presence of polyp require regular follow-up? And only the size of polyp is the criteria for surgery?
One of the criteria for surgery is definitely the size of the polyp being more than 5 centimeters. Another uh, consideration, like I've already discussed, is calcification of these polyps and increasing numbers of polyps. If your number and size is increasing on your regular follow-up at 6-12 monthly intervals, it is safe to go in and do a laparoscopic cholecystectomy. If your patient is unwilling, please educate them about the risks of CAGB, which are known to be higher with larger sized multiple polyps. So that is something to be kept in mind.
So some questions on UDCA. I hope I'm addressing it together. Dr. Patil says dosage and role of UDCA in GB with multiple calculi without cholecystitis along with grade 1 fatty liver. Would you recommend UDCA in elderly patient with dyslipidemia? Also, does it really help as per your experience in clinical practice, sir? Role of fenofibrate along with rosuvastatin combination to tackle fatty liver alongside GB calculi.
So, combination of questions. Let's start with the first one. Dosage and role of UDCA and GB with multiple calculi. Personally, I'm not a big fan of UDCA. It doesn't help much. And in a patient with GB multiple calculi, where you say the maximum size is 1 centimeter, you're talking about a patient who is very likely to finally go for some sort of pancreatitis and cholangitis. So I would, rather than putting this patient on UDCA, ask the patient to undergo a lap cholecystectomy. But if the patient is unwilling for the same, I would start in the at the dose of 300 milligrams at least 3 times a day. Please keep in mind UDCA is not exactly cheap, and the results tend to be seen in less than 20% of the patients. Grade 1 fatty liver is a completely separate issue, and there is no role, as far as I see, with the treatment of fatty liver through UDCA. UDCA is no better than placebo when it comes to the treatment of fatty liver. Regarding recommending elderly patients with dyslipidemia for UDCA, I do not do that at all because it doesn't work, and I would not. I can't fathom why anybody would want to give UDCA for dyslipidemia. Does it really help as per your experience? I think I've already answered that. It doesn't. There is a limited role of fenofibrate along with rosuvastatin combination to tackle fatty liver alongside GB calculi. Now, the GB calculi here is not the reason you are giving fenofibrate and rosuvastatin. Please keep that in mind. You are basically giving it for the fatty liver. Again, the jury is out on the combination of fenofibrate with rosuvastatin for fatty liver. I think fatty liver is a completely separate issue to be addressed completely differently with drugs like saroglitazar and the new PPAR agonists and all which are coming into the market, We have resmetirom, which has come into the market in the US. However, that is something which is not going to be easily available in India. It's an extremely expensive drug. I don't think there is any point discussing that here. But when we talk about fatty liver alongside GB calculi, the GB calculi has to be tackled independent of the fatty liver. The fatty liver is a completely separate issue, and the GB calculi is a completely separate.
So this particular question we had received on the session flyer as well. Dr. Parvati says cholecystectomy patient is having urgency in defecation even after 10 years. So what should we do?
So, Dr. Parvati, I'm assuming that you already ruled out things like IBS, infectious colitis, IBD, celiac disease, and so on and so forth. Because just because a patient had cholecystectomy and now has diarrhea does not mean that it is due to the cholecystectomy. I'm assuming that you have already ruled out the other varieties of diarrheas, and now your concern is the urgency. Now, this could be true bile acid diarrhea, though we rarely see that after 10 years, but yes, it can happen. What you should do is ask the patient to cut down fat, and you could give them bile acid sequestrants like cholestyramine 3 times a day. 400 milligram tablets will do the job for you. Most of these patients settle down quite rapidly with that and tend to do very well.
So would you like to proceed with a few more questions?
Sure, please go ahead.
Okay. Next is from Dr. Rawal. Single episode of acute cholecystitis, no stones. Is it an indication of cholecystectomy?
Yes, definitely, Dr. Raval. If it is acute cholecystitis, even if there is no presence of stones, it is still an indication of cholecystectomy. The reason being that acute on chronic cholecystitis is known as a risk factor, a pre-malignant factor, and these patients can decompensate quite badly. So you can get acute acalculous cholecystitis, which I have already discussed. AAC is something which is very, very commonly seen, and it is a definite indication of cholecystectomy if you have a well documented episode of acute cholecystitis.
Uh, Dr. Gautam has another question. As there is Murphy sign for acute cholecystitis, is there any sign for chronic cholecystitis and porcelain gallbladder?
So you can get a positive Murphy's sign even with chronic cholecystitis and porcelain gallbladder, because Murphy's sign is basically a sign of inflammation. It could be existent with acute, chronic as well as porcelain gallbladder. Now, when you talk about signs, porcelain gallbladder, there are a lot of radiological signs through CT, MRCP, and endosono, where we know when we see porcelain gallbladder, we know. Chronic cholecystitis is usually distinguished on US sonography, CT, and MR by the signs of thickening of the gallbladder mucosa and an overall roughening of the rugae, which are very clearly seen with triple phase CTs these days. And these are the patients, those are the signs we look for. So Murphy's sign is more reliable for acute cholecystitis. However, Murphy's sign can be present in more than half of your patients with chronic cholecystitis who could have acute on chronic cholecystitis and porcelain gallbladder whenever they are having an acute inflammatory episode going on.
So Dr. Shah says, is there any medical or drug treatment to dissolve gallstone?
Unfortunately, nothing works. A lot of diluents and therapies have been tried in the past, even putting in a catheter inside the gallbladder and infusing it with solvents and all. It really doesn't work. The only thing, like I said, which gives you some sort of benefit in limited numbers is UDCA. But then again, UDCA is an expensive modality for limited benefit. So I would say medical or drug treatment to resolve gallstones is non-existent as of now.
So Dr. Sumita Thomas says, so with elevated levels of liver enzymes, is it better to do a CT or MRCP before cholecystectomy?
Great question. I would say an MRCP would be better, because an MRCP would also show you the biliary tree much better than the CT. The CT would be better if you are suspecting hepatic abscess or something involving the liver, which you wanted to see better, because the liver would show up much better on the CT, whereas an MRCP would give you the biliary tree anatomy much better. So before a cholecystectomy, I would more rely on an MRCP if there were elevated levels of liver enzymes rather than doing a CT.
Dr. Gautam says, can UDCA dissolve gallstones?
Not in my experience, Dr. Gautam. Though there are some papers which do say limited benefit. Personally, I have yet to see them after 30 years of doing it.
So, doctors, we can take the last two questions for tonight. Next is again from Dr. Shah. Role of doing serum alkaline phosphatase in management of gallstone or considering cholecystectomy.
So, Dr. Shah, like I said, serum alkaline phosphatase is a very, very sensitive marker of cholestasis, and it tells you that there is an element of obstruction or stasis. So, if you have the suspicion of a gallstone which is leading to obstructive pathology, you would have raised alkaline phosphatase. And therefore, when you are considering a cholecystectomy and you have a patient who is symptomatic for gallstone, has elevated liver enzymes and deranged alkaline phosphatase, this is a patient where you want to do an ERCP first to take out any stone in the CBD and then proceed with cholecystectomy. So the role of alkaline phosphatase is definitely important. First for the diagnosis of obstruction, later on to tell you that you have been able to clear out the obstruction before you proceed with cholecystectomy post ERCP and drainage.
So, doctors, taking the last question for tonight, it is from Dr. Parvati. Is microscopic colitis common after cholecystectomy, and what are the symptoms of the same?
Yeah, Dr. Parvati, microscopic colitis itself is not a very common condition. So making it in that subset of common after cholecystectomy, not so much. Symptoms are usually you have basically small volume diarrhea. These are patients who tend to lose weight, and the clue lies in doing biopsies from multiple places in the colon. Collagenous colitis, microscopic colitis are basically diagnoses of exclusion. One needs to be aware of these, and an experienced endoscopist can definitely identify some signs which can point you in that direction. But the final word on microscopic colitis has to be the histologist. So one needs to take adequate amounts of 4-quadrant biopsies, and an experienced histopathologist will be able to give you the diagnosis of microscopic colitis.
So I would like to thank sir for answering so many questions very patiently. And also, doctors, I think we have answered most of your questions. In case we have missed any questions of yours, you can still post it under the flyer of the discussion. And yes, the replay of the session will be uploaded on the Medflix app. You can still post the questions under the flyer, and we'll definitely try and get it answered from sir. With this, I would like to thank Sir for such a wonderful session and for taking so many questions. It's always a great time having Sir with us, and thank you so much for doing this session, Sir.
Thank you, Barsha. Thank you so much.
Thank
Thank
you.
you, everyone. Good night.